So this is a case about differential diagnosis in asthma, because sometimes we feel that everything is done and asthma is there and we are treating, but sometimes we are losing some points and there are things that we are misunderstanding or we are, not getting to the point. This is my declaration of interest. A lot of companies there from all over the world. So, of course, we are now in the pandemic situation and we have to make a telephone consultation, and that adds another problem to our day-to-day life and our day-to-day practicing. So today we have a telephone consultation in our agenda, in our list of patients, and we see that Sarah is there waiting for us to call her. She's a 32 years old woman. She's teacher. She teaches maths in Mallorca here. I live in Mallorca in a high school. And she's been suffering asthma from her early childhood. She's also allergic, no other respiratory or general conditions, or not anything. And now we see in our files that she's prescribed on ICS LABA, corticosteroids, inhaled corticosteroids, and long-acting bronchodilators for maintenance therapy, and then salbutamol as needed for relief and for rescue medication. And she asked for asthma review remote consultation. So we take a look at the files and we can see that following GINA guidelines or all guidelines in the world, she was very well diagnosed with asthma a long time ago. We can see in our files her spirometry with great hyperresponsiveness, bronchodilator test, a positive bronchodilator test that can confirm the diagnosis of asthma. And this was made a long time ago, years ago, when she was early in the adolescent, about 10 years old. We keep on seeing the files and we see that asthma has not been the same for all her life, and different severity asthma periods has happened. In the childhood, she was in regular maintenance therapy. Maybe her parents were making her to make the right treatment, but then adolescence came and she gave up the treatment. She was not visiting us, but finally nothing happened. So she had no flare-ups. It seems like her asthma was well controlled with no medication, and this sometimes happens. Still asthma is there, but sometimes they adapt to short to small symptoms and they have no flare-ups. So she was living with her asthma like that. But 2 years ago, she began to play sports. She began to jog, and then he began to suffer many exacerbations. And she came back to us to tell us, "Doctor, I have been for nearly 10 years with no asthma symptoms, very well with my asthma, some salbutamol once a month, twice a month, and that was all. And now I'm suffering a lot from asthma and I cannot make my exercise in the way I should like." So we can see that something is happening and we have to make something on that. So we take the phone, we call her, and we make the anamnesis, we make the questions to her to see what's happening. And this is what she told us. No night awakenings, only breathlessness during exercise, no more breathlessness during the day, not in class, not when she's making her normal life. But he has increased the control of medication. She's in budesonide and formoterol, and she has doubled the dose. She's now twice a day, 2 puffs in the morning and 2 puffs by night, according to the personal asthma action plan that we gave to her 2 or 3 months ago when she consulted for this situation, this changing situation.
So Miguel, I just had a question here. You mentioned that she was using a salbutamol inhaler when she gets breathless during exercise. Is that what you would recommend these days for relief in exercise? Or there has been some talk about using steroid even for that. What's your view there?
Yeah, the problem sometimes it's better to put some corticosteroids for as reliever, because then you are getting some anti-inflammatory drug on top of the bronchodilation. But in this case, you can see here that she was already taking twice a day her controller medication. The adherence was good. So maybe an extra salbutamol, maybe an extra controller could also work. But then we decided to put on salbutamol alone for the.
Sujit, I agree with Miguel on this point. Although it's important to make sure the patient has enough inhaled corticosteroid, in this case, she's done exactly the right thing by following her personal asthma action plan and doubling her controller medication. So it's entirely appropriate to use the salbutamol here, given that she's got a good dose of baseline inhaled corticosteroid.
Sure. Thanks for that, John. Thank you. Please, Miguel, continue.
And I put here the ACT because, of course, in a telephone consultation, we cannot make an ACT to the patient because she has to make it in the paper or maybe online. But I wanted to put it here because normally when I'm in the consultation with asthmatic patients in front of me in face-to-face consultation, I always give them the ACT to complete. And I think this is a very important point because then we speak the same language. It's important that when we measure the control of the patient, we are speaking the same language. And it's not the same to say, how are you? I'm fine, no symptoms. When we have it in the paper with a number, with the scoring, I think it's better for the understanding of all the professionals around her asthma.
Do you think this is really, because I see a lot of respiratory physicians not using the ACT, and you're a primary care physician, so that's fantastic. Do you see huge value in getting those scores, Miguel?
Absolutely, because as I'm telling you, the right way to measure it, because then we have an objective measurement, not only how are you, that sometimes, and of course it fails, and not to say, but if you repeat it on time, you can see the evolution of the asthma. And when others professionals go, for example, for emergency department, or when they go to the pneumologist or to the specialist, they can see a number, something that had happened in the last times, in the last years or months. So I think it's very important to promote the use of this kind of questionnaire, maybe this one or another one, but promote the use of questionnaires to control asthma. Some people is overusing SAVA with no control medication. And of course, that could be another question apart from the questionnaire. But I think we always have to make this question: how many salbutamol puffs or how many salbutamol cans are you using by month, by year?
Sure. No, I think it's a great take home for both respiratory physicians and for physicians who see a lot of asthma. It's a superb message that you've driven in here. Please continue, Miguel.
So the diagnosis is that Sarah has an uncontrolled asthma. It's clear that it's 18, less than 20 in the questionnaire is an uncontrolled asthma. And as we can see, something is happening. Of course, it's not a bad situation because day-to-day life is okay, but the sports is very important for her now, and we see that something is happening. So this is a paper from John, and then another people from IPCRG. In IPCRG, we have another desktop helper on this called Simples. When you have an uncontrolled patient, you have to do something. And these are all the things that can lead the patient to a out of control situation. And of course, in this case, maybe we have to go for incorrect diagnosis because we have the diagnosis made a lot of time ago in the past, nothing happened, and now something is happening. And we have to interview the patient more deeply to see what is happening. Okay, so we know that to confirm asthma diagnosis, we have to see symptoms, variable, maybe exercise, viral infection, or allergens can promote the crisis or the symptomatic periods. It can appear early from childhood. Maybe it can appear also in older people, but it's normal to appear in childhood. And it is accompanied by crisis of bronchospasm. That's asthma, symptomatic asthma, suspicion of asthma. And then we have to make a spirometry to confirm the diagnosis. And of course, sometimes a spirometry won't give us the diagnosis and we have to make more tests, or we have to make variability tests with peak flow, or we have to make FeNO or something like that. But if we have a reversibility test, we have the correct asthma diagnosis in front of these symptoms. And this was done with Sarah in the past. Yeah. So in summary, in Sarah, we have a proper asthma diagnosis made in the childhood. She has been free of symptoms and no need of maintenance medication for years. But 2 years ago, she increased the use of rescue medication, especially during exercise. She hasn't responded to increasing control of medication, as we have told us for her self-management plan. And we don't find any of these conditions that could promote a lack of control, like smoking, new medication as beta blockers or something like that, no new allergens exposure. She has no move to another home or a new boyfriend or something like that, or a cat or a dog. And the medication adherence is good because we know that she makes the medication, she's taking it from the pharmacy, and we know that she has a very good inhaler technique because we have checked that in the past. So, what's the problem? Maybe here we have to take a look at this in red, the no response to increased control medication, because asthma normally responds very well to inhaled corticosteroids. Not in severe asthma cases, but as you can see here, it's not a severe asthma because she has no worsening by night, she's not flare-ups, but she's still having this problem with the exercise that is not responding to control medication. So this is not a normal increasing severity case of asthma. Something more is happening. So sometimes we have to look for another thing. So let's go back to Sarah and the telephone and ask her more depthly what is happening. And then in the interview, we ask for other symptoms. And then you can see these symptoms there that are clearly giving us an idea of something that could happen in the upper airways. If you see here, the symptoms are hoarse voice changes. She reacts to this, telling that she's a teacher, and many teachers, as herself, they have problems because they speak too much in the classroom, and then they have this hoarse voice. And so she adapts her situation to this, and she thinks that this is the cause. But we have a clear diagnosis when you have this problem. It's vocal cord dysfunction. And maybe this is the problem with Sarah. When we speak, the cords, our vocal cords, they nearly close at all, and they vibrate, okay, to make the voice, to produce the voice. But when we take air, when we inspire and the air goes on, then the cords open widely to allow the air to come in. But in this situation, in this vocal cord dysfunction, related to some triggers that can be very variable, and exercise is one of them, the vocal cords, they remain closed when we try to get air in. And that's the situation that promotes a kind of asthma symptoms, more inspiratory than expiratory airflow obstruction, and a distress and a breathlessness that is not getting better with the medication. How we diagnose vocal cord dysfunction? Mostly we can conduct an spirometry in primary care. I don't know in your countries, but in Spain we have availability of spirometry in every primary care practice. It's more or less used, somewhere they use it more, somewhere they use it less, but we have this available. And then with an spirometry, we make the inspiratory curve. Here you can see that the inspiratory curve can flat because when the air comes in, okay, the not widening of the vocal cord of the larynx make this cord too flat, okay?
Right.
Of course, this can happen when the situation is happening and not always, because as you remember, Sarah is okay all day long, and this situation is only happening with exercise. That is very typical from this dysfunction. So maybe we need another test to see what is happening. And the confirmatory test, the gold standard for the diagnosis is laryngoscopy. Okay, we made a laryngoscopy, a video laryngoscopy, and we say the patients to take air in and out, and then we can see that these are normal closing cords during inspiration.
Sure. So I see that, Miguel, a lot of these things would be happening when the patient has symptoms, am I right? And so the challenge is to do this in primary care and you say most GPs in Spain have a spirometer. I don't think that's the case all over the world, and maybe not even in the UK. I'm not sure John's thoughts on that. But in the absence of getting that spirometry done, if the patient has no symptoms when they reach the clinic, I guess it's history largely, or do you provoke exercise? What do you do, Miguel?
Yeah, this is not a very usual situation.
Sure.
It's a condition that is not very usual, but in some cases like this, we have to be aware that it exists and think of it. And maybe the best option when we think of it is directly make a referral to the ENT, because they will have the choice. But maybe if we have for example, in young people, because it's not recommended in adult people, because you can promote a stroke or a myocardial infarction or so, you can make an exercise test, as you can see in the picture. Okay, this is treadmill that is not available in primary care, but in primary care we have made in children some exercise tests for exercise-induced asthma, and just make the children to go up and down the stairs to promote they have an increase in the heart frequency, and then when they're a little bit tired, we make spirometry. So it could be, but if they are older people, we are in a risk of making this in primary care, because we are not in the best situation. If something more is happening, if we can promote another more severe situation with the exercise. But it could be done. But of course, I agree with you that maybe it's better to, if we suspect it, to send directly to the ENT.
So, John, any thoughts in primary care in the UK and Scotland? Obviously, you're restricted by NHS to refer everyone to an ENT surgeon and a laryngoscopy. So, what would your message be to physicians suspecting this condition?
I think the first thing we have to do, Suji, is recognise that colleagues in different countries have different availability of these kind of tests.
Right.
And one of the reasons we are discussing, the three of us are discussing this diagnosis today, is because we suspect that it's more common than we previously thought.
Right.
But we can't really prove that unless we go to the point of making a final diagnosis. So we're now suspecting that more people have vocal cord dysfunction than we previously thought. And by talking about it today, we can raise awareness amongst our colleagues to be aware of it. But there are some problems. So one of the features I take from it, just in terms of clinical examination, by phone or in person, is that there's a problem with inspiratory issues rather than expiratory. Now that's quite important, but it's quite a subtle diagnosis, a conversation to have. For instance, the big problem with asthma isn't so much breathing in, it's breathing out. So people who've got uncontrolled asthma are hyperinflated. So just to give you an example of that, if you take a deep breath, and then I tell you to take a deep breath, it's very difficult to do because I can't take a deep breath twice, and therefore I've got an inspiratory problem, as if I have asthma. So we have to differentiate between the vocal cord issue and badly controlled asthma. And actually, this is what the point is really all about. Yes. True exercise-induced asthma, which I prefer to call exercise-induced bronchospasm, isn't type 2 asthma. It's not to do with eosinophils. The pheno's not high. It responds to bronchodilators. It doesn't need corticosteroids. But the alternative, which is asthma symptoms on exercise in somebody who has poorly controlled asthma, is just normal asthma, and it's being exposed when somebody exercises. So now we've got three different things. We've got poorly controlled asthma that needs to be treated as normal. We've got exercise-induced bronchospasm, and then we've got vocal cord dysfunction, laryngeal spasm, and so on, which is, almost a different condition but coexisting. So we need to be aware of it. You're right. We're not going to get spirometry at the right time in everybody. We're not going to be able to refer everybody to an ENT surgeon for laryngoscopy. But what we're not going to do is just write this off as uncontrolled asthma. We have to recognize it as a separate condition.
Excellent points. Thank you. Thank you, John. And very, very useful clinically as well. Please, Miguel, continue.
Yeah, just an image that it was funny for me because, of course, the laryngospasm must be demonstrated also in the ENT surgery with exercise-induced situation. And this is the photo that I found in the internet of how difficult it should be to make this test in the hospitals. Wow. Just because it was funny for me to see the picture. Okay, right. Everything that you need. This is important because, as John says, it's three situations, and maybe to refer for the ENT surgeon, the best way is to get the diagnosis or the suspicion to increase the possibilities of this situation, of this disease. And as you can see, difficulty breathing in, not out, as John very well explained. The peak is a maximum exercise, while in asthma, in exercise-induced bronchospasm, you can see that it happens after the exercise. Okay, sure. You make the exercise, you can do it well, and then the normal situation is that 10 minutes, 15 minutes, when you stop, then you feel your asthma coming. Sure. The tightness in the asthma, of course, is in the chest. And in this situation, in the vocal cord dysfunction, it is more related to the throat. Okay? It recovers very, very quick, and the asthma attack can be more delayed in time, and it can recover in hours. And then, of course, the response to the drugs, because normally, if you put salbutamol in asthma, exercise-induced asthma, it works, and it doesn't work in vocal cord dysfunction. So this is important before we make the suspicion of the diagnosis. So for Sarah, let's go back to Sarah, and we finish we refer her to the ENT. They made the laryngoscopy, and then they send Sarah back to us with this diagnosis, induced laryngeal obstruction. And we say, oh my God, what is this? I thought it was vocal cord dysfunction. Okay, don't worry, it's the same. Sometimes doctors, we speak different languages to say the same things. So you're not more than me. So we have this, and then we have to make any treatment for her. And this is good news because this situation will never put her in danger. She has not hospitalizations for this, and we can go slowly to get the treatment done. And the treatment basically is to avoid triggers, but of course in this case, to avoid exercise, I don't think is a good option for us, because she loves it and it's good for her health in general. So in this case, I don't think we can avoid the triggers. Then sometimes, because I haven't said that sometimes this situation is not only promoted by exercise, there are other conditions that can promote this to happen, like anxiety and depression is very much related to psychopathological things, and then the reflux and rhinosinusitis. And you can see here that all these conditions can also make asthma worsen. So this is another problem, because sometimes it's exercise, sometimes it's all of these conditions that promote the vocal cord dysfunction, and these are the same situations that can promote asthma crisis. We can consider inhaled anticholinergic drugs, so ipratropium or something like that, but it's not clear the evidence that this works. Of course, we have to continue with asthma medication, because Sarah is not only suffering from bronchochordal dysfunction, she's suffering from her asthma, and maybe we can go back to one puff twice a day and not increasing the medication, because now we have the problem identify what is happening, but she has to continue with the control medication, of course. And then the most important thing for vocal cord dysfunction, that is the treatment made by the speech therapists. And they make a different kind of exercises with the voice, exercises with the cords, special breathing exercises, and relaxes inhalation, and these techniques that sometimes, and of course, they work.
So, fantastic. I mean, yeah, please continue. Yes.
This is the message to take home, okay? So we have always to confirm the asthma diagnosis when we have in front of us an uncontrolled patient. This is the first point. Is this asthma? Is anything else? Vocal cord dysfunction can be easily taken as asthma. We must make the differential diagnosis. Induced laryngeal obstruction can be difficult to distinguish from asthma, and it may coexist also with asthma, like in this case from Sarah. And we can try to get the inspiratory curve of the spirometry, because sometimes we can get the diagnosis from there. And of course, once we have not the possibility to make more tests, the ENT and the speech therapists are needed to get the right diagnosis and the right treatment for this condition.
Oh, fascinating case, Miguel. I'm just thinking, actually, a question to both of you all. I think all three of us see patients, especially younger women, I have noticed, with what we would call functional dyspnea, where they're breathless and we don't feel there's any problem with their lungs or their vocal cords. Do you think a lot of this could be VCD? And if it isn't VCD, would they be benefited, you think, with a speech therapist? Because I really don't know what to advise them sometimes, because they come in breathless and there's nothing wrong. The spirometry is normal. There's no inspiratory flattening. And they've been given multiple medications by primary care providers looking at, bronchitis, asthma, and the works. What's your thought to deal with it? I mean, I call it functional dyspnea, and one of the doctors who was a patient came back and said, no, I know my diagnosis. It's sighing dyspnea. So she found this diagnosis on the internet and said she has sighing dyspnea. Miguel, what's your thought?
Well, absolutely right. There are some people, and I have a colleague from mine, and we started, she's a yoga teacher, okay?
Right.
And we started a randomized control trial in rehabilitation, in respiratory rehabilitation in primary care because of her. Because in yoga classes, she thought and she observed it that a lot of people, they don't know how to breathe.
Right.
And she said, so sometimes asthma, or we are thinking that it's asthma that is uncontrolled, but it's because people, they haven't learned to correctly breathe. So right. Absolutely what you say.
John, sighing dyspnea, have I given you another diagnosis or?
Yes, so you call it functional dyspnea, we call it dysfunctional breathing. Now, right. Some people have genuinely dysfunctional breathing, which is to do with anxiety and psychological symptoms. But I think this is where we again get into quite a difficult diagnostic area, because as well as having asthma, you might then develop inappropriate breathing. Yes. The first time you suffer symptoms of asthma, the likelihood is you'll panic. And if you panic, your breathing pattern will change and it might make you worse. Similarly, you could have dysfunctional breathing or inappropriate breathing as a result of your vocal cord issue. So then you're compounding a number of different diagnoses. And the problem we've got just now is it's quite difficult to tease them all out, all the different diagnoses in primary care. And any of you who have access to secondary care will know that we're not conducting the kind of exercise laryngoscopy tests at the moment that Miguel showed. I mean, they're probably aerosol generating and therefore won't be allowed. And the hospitals are under such great pressure and are likely to be for the next year or two that we're just going to have to do our best and use our clinical skills. I think the problem is that you can get inappropriate breathing on top of asthma and inappropriate breathing without asthma. And there's a danger that we'll discard everybody who has dysfunctional breathing as something different to asthma, and we won't treat their asthma. So it's going to be a very, very difficult balance for us to find.
No, that's very true. And I think this case had so many messages, and I think primary care physicians will go home with some good messages on asthma, the differential that you brought out beautifully, Miguel.